So the International Society for Rapid Response Systems, of which I'm now president, has come about because clinicians all over the world have recognised that we've got a real problem dealing with patients at risk of deterioration in the hospital and probably outside the hospital too. And we've got together a group of clinicians and administrators and managers, but particularly clinicians, who can bring together the best of the work from around the world to deal with this issue. We're really excited to be alongside the Patient Safety Congress this time, which is the first time, and that's because we think that our bottom-up, clinician-led approach needs to be merged with the thinking that comes down from policymakers and administrators at the top level. We can both learn from each other, and we can both focus on proper quality improvement of processes to help these patients at risk. The key themes for me are that we've come on leaps and bounds in identifying at-risk patients, and we're very much aided by new technology with regard to that. That's both in terms of monitoring and understanding big data. We've come to understand that some of the patients that we're called to see who are in extremis are actually dying and cannot be saved even by heroic measures, and we need to treat those people with dignity. So we're working hard with those people that deal with patients at the end of life. And we've also come to understand that at the heart of all of this is a need to change the thinking and the culture right across the hospital, from the shop floor to the boardroom. And that's why we think that working with the Patient Safety Congress, where some of those themes have already emerged, will be critical this year. So delegates this year are going to get the chance to hear all about the new approaches to identifying sick patients. Here in the UK, we're in the vanguard in the world with the new National Early Warning Score that was published last December. And we're also going to hear about some of the systems that have developed that incorporate 10 or 20 or 30 or 50 or 100 parameters for really getting on top of which patients are sick and which patients are going to get sick. We are going to focus very particularly on sepsis, which is probably the biggest killer of patients in the hospital setting, and talk about our work to identify and manage those patients better. And we're going to talk a lot about the human factors underpinning poor performance and what can be done to improve performance by understanding and developing a human factors-based approach. I can honestly say that we've got together pretty well the best people in the entire world to talk about the issues at hand. We would include in that Ken Hillman, who really invented the rapid response system, first working in London and later in Australia back in the late 70s and 80s and 90s. And he's also particularly come to understand the intersection between acute care and end-of-life care. We've got Dana Edelson from Chicago, who has taken the whole recognition of deteriorating patients using big data to another level. We've got Professor Mervyn Singer, who is probably the world's leader on the understanding of sepsis and how it might be managed. We've got Gillian Hartin, who's going to talk to us about how we can have a conversation with patients and relatives about those cases where we cannot be heroic and help them understand how we can manage them better. We've got several human factors experts, including Siri Steimo, who's going to help us understand human factors on the actual shop floor in a practical sense, how they can be understood and how they can be developed so that people do the right thing. And underpinning the whole thing, I guess, is the idea that we're going to have patients involved in shaping the care of the future, and the patient input into recognition of deterioration and managing deterioration and doing it properly is absolutely paramount. There's a problem of deterioration and management of deterioration in the NHS and around the world. It's a universal issue. There are several reasons. One is that patients today in the hospital are sicker, more complex, and have more chronic diseases than ever before, but we haven't increased staffing levels on the wards to help deal with that increase in acuity and dependency. Patients are vulnerable, and we sometimes make mistakes in identifying deterioration early on in the patient's case. Patients can then deteriorate without being noticed properly. That means that organ failure can then set in, and it's then very difficult to treat. So this is a problem of resources, but also a problem of approaches. What the rapid response system brings to the problem is that we have systemised identification of deteriorating patients. We've worked out what the response is likely to be, And we've also come to understand the difficult thing, that this is about changing behaviour and culture. And that's really what we're starting to get to grips with now. And it's a hospital-wide issue. We know that of the patients that the rapid response team is called to see, in England we call that the critical care outreach team, between 1 in 4 and 1 in 5 will die in the next month. That's a high mortality rate, and that's a higher mortality rate than for pretty well any other group of patients in the hospital. We know that a lot of those patients will die from sepsis, and there's a lot of attention being paid to sepsis, but more attention needs to be applied to that particular issue. And patients can die very rapidly right across the age range.